Okay. Good evening, everybody. Thanks, Matteo. Present me. I am Annachiara Carrozza. I am attending the last year of medical school in San Raffaele, and I hope to become a geneticist. In this presentation, we talk to you about a medical condition that is way more frequent than you may think. I'll make a small off topic to talk to you about this sculpture depicting Hermaphrodito, the main character of many Greek legends from ancient time that is at the Louvre Museum at the Uffizi Gallery. Somebody, not some particular of this sculpture?
I know.
What is?
There is something between the legs, but also a scene.
Okay. Okay.
Breast the penis.
Yes, exactly. In this sculpture, there are both penis and breast. In fact, this is Hermaphrodito, is a character from Greek mythology, son of Hermes and Hermaphrodite, a goddess of beauty, love, and sexuality. According to Latin poet Publio Ovidio Naso, Hermaphroditus was a very handsome boy who was transformed into an androgynous being by the supernatural physical union that took place with the nymph Salmace. This happened because the nymph, when she saw Hermaphrodite, she fell immediately in love with him, but her love was not returned. And for this reason, she asked the gods to bind herself to Hermaphrodito forever, and when she managed to kiss him, the gods fulfill her desire. A single being was therefore created. The two bodies were mixed into a creature of both sexes, half male and half female. I talk about this legend to underline how, even in ancient times, people were aware of the existence of such a figure. Another representation these figures are present in the history are androgynes and putti that we can find in a lot of famous pain such as Raffaello's putti. As far as we know, only in the 1876, Klebs tried to classify this condition for the first time. He used the term such true sexual ambiguity or true hermaphroditism that define the individuals who have both male and female gonads, and the term pseudohermaphroditism for the individuals who have a typical genital appearance but don't have both male and female gonads. But during the 20th century, the sexual chromosome was discovered, which contains the sex-determining region Y. Was discovered the karyotype, as well as the several mechanisms that determine sexual development. For these reasons, in 2006, the Chicago Concision meeting suggested the potentiality harmful terms such as hermaphroditism and intersex had to be replaced by the diagnostic category appunto disorder of sex development. The appropriate term of this DSD has many times been criticized because of three different reasons. The word disorder is seen as a necessarily negative by some, and is frequently replaced by the term difference. The second problem is the DSD. In the DSD, an overly broad term that could be interpreted to encompass condition in which no uses with genital appearance of or gender identity are expected. And the third problem is that an umbrella term like DSD is unnecessary because it lacks sufficient specificity to be helpful diagnostically. Many support group and advocacy group do not accept the DSD designation and feel that it should be abandoned by the medical community. Therefore, in this moment, I use the term DSD like all the studies so far have been doing until the consensus is resides for these uses. And for the moment, we can define this condition like a congenital condition within which the development of chromosomal, gonadal, and anatomical sex is atypical. Then we can see that also today there isn't any clear definition of this condition, but both because the causes are many and also because the people have started to pay attention to such condition only in recent period, which as a consequence lead to the presence of few long-term data. Despite the frequency of this condition occur approximately every 1,000 to 4,500 births. But the number receives considering that many people are unaware that they bear this condition. Indeed, this condition have several clinical manifestations. There are people that don't have any particular symptom or signs of this condition and show sexual organs that are typical of only one specific sex, totally male or female, but their sexual chromosomes are non-concordant. The only manifestation that these patients have, which is the causes that lead them to clinical observation, is infertility and absence of the menstrual cycle. Then there are individuals with DSD that may have complete absence gonal development, partial but incomplete gonal development, or a gonad with both ovarian and testicular features. They may gonad located in abdomen, the inguinal region, or in the labial scrotal fold, such as this picture. And individual may have a urethral meatus located in anywhere between the tip of the gland and the perineum. They may have hypospadia or micropenis or clitoromegalia. They may also have varying degrees of development of Wolfram and Mullerian structure and asymmetric gonal function in the internal reproductive structure. Now we can understand who we must consider that it is a condition that does not only concern physical health of the person who's affected, but also the psychological one, most regarding to understanding of oneself and the relationship with the society. For some rare type of DSD, gender identity is unclear or difficult to predict. Thus, decision about gender of rearing should be individualized. In some of these cases, it's helpful to promote the concept of evolving gender identity, which recognizes that gender identity may change as the child grows. Decision about the sex of rearing depending in part on the predicted gender identity, which varies with the type of DSD, but not always predictable. Similar question about time of surgery. Some experts support performing some components of surgery, such as repair of urogenital sinus, vaginoplastic, and labioplastic during the infancy. Then another expert groups argue that all surgery be postponed until the child can fully understand and make choice about surgery. A similar argument can be made with the hormone therapy. The presence of a sign rather than another depend on the causes of the condition. The causes are many and they may occur at any steps of the sexual development. In order to better to understand, we divide the sex development into different processes. The determination of sex, in which is the destination of the undifferentiated gonad to form the testis or ovary, and which is a process that is genetically programmed in a critical way by chromosomal sex and genetic sex. Then the second step is sex differentiation, which takes place through the hormone produced by the gonad, both during their formations and once they have been formed. Disruption of any of genes involved in this process during the course of testicular or ovarian development or in the subsex sex differentiation could lead to DSD. There are a lot of classification to describe the subtypes condition of DSD. For example, this table is a pathophysiology and clinical classification of the anomalies or disorder of sex development. I don't prefer use this classification because this doesn't individual the base forms. There is a problem, and because of, for me, is more easy to think to genes, I proposed classification grouped by karyotype and mechanism. We can see that disorder causes atypical genitalia in the XX individual's chromosome is caused by a typical high level of androgen, which can be due to overproduction of androgen by the adrenal cortex, by the gonads, or an ectopic or exogenous source of androgen. The different mechanisms responsible for this condition are, for the most common causes, is a typical is classical congenital hyperplasia due to 21 hydroxylase deficiency, which causes virilization in individual with an XX karyotype. prompt recognition and treatment are important to avoid the possibility of early adrenal crisis. Less common cases of congenital adrenal hyperplasia due to 11 beta hydroxylase deficiency and alteration of POR, another enzyme involved in the production of adrenal hormone. Another causes is testicular DSD and over testicular DSD. The XX testicular DSD is a term for condition in which the gonads develop along the testicular rather than the ovarian pathway. Causes of this condition or the over testicular DSD include the presence of SRY to the X chromosome or an autosome chromosome, and accounts for roughly 1/2 of cases of XX testicular DSD. Another cause is mutation in NR5A1. A gene has long been known to play a central role in the initial gonad development and testicular differentiation. Another involved gene is, for example, duplication of SOX9, inappropriate expression on SOX3, loss of function mutation in gene that repress testicular pathways such as Wnt4, that is a gene that involved also in another kind of organ development such as lung, and for these reasons the presence of mutation to this gene is associated with this genesis of lungs. Another rarely condition is gestational hyperandrogenism due to export to maternal androgen, such as presence of maternal leutoma. Then the causes of atypical genitalia in XY individual are atypical low levels of hydrotestosterone action, production, and ability to respond it. Then we have gonal dysgenesis leading to global defects in testicular function with production of testosterone, anti-Mullerian hormone, and inhibin. These conditions are causes, for example, another kind of mutation on SRY, mutation in Wnt, in SOX9, loss of function mutation in gene essential for testicular development, such as Wnt1. And in this group, there is also testicular dysfunction without atypical genitalia. In this condition, there is a normal external male genitalia, but is presence of some Muller structures such as ureters that may be discovered only incidentally. Also, in this group, there is another another forms of congenital adrenal hyperplasia, different by the forms present in the individual with XX karyotype. And in these groups, there is the disorder with abnormal androgen synthesis, included the defect of luteinizant hormone and human chorionic gonadotropin receptor. And another type of causes is androgen insensitivity syndrome due to impairment on function of the androgen receptor. Another causes is mosaicism or chimerism resulting to the presence of the Y chromosome in some cells, but not in others, which may result in the atypical genitalia that presents different phenotype in the affected individuals. The diagnostic approach involves each of following steps. The first steps is it's important to diagnose and treat congenital adrenal hyperplasia because of the associated risk for adrenal crisis is very it's very strong correlated, and for do this we evaluate the 70 hydroprogesterone or use a stimulation test with adrenocorticotrope or more. The initial evaluation should include pregnancy and family history. The history in a child with DSD should include the prenatal exposure to androgen, such as use of danazol in the mother, or the presence of another endocrine disruptor that determine in the mother a kind of virilization. It's important to identify the history of consanguinity of genetical homogeneous population, which would increase suspicion for recessive disorders such as congenital adrenal hyperplasia. After physical examination should include careful inspection and palpation of the genitalia to find the ambiguous genitalia that I showed early. In this picture, it's represented the virilization scale that it's important instrument to do a good physical examination. It's important to observe associated non-genital anomalies, so dysmorphic featuring, because it should be documented a non-common congenital adrenal hyperplasia. Then we do karyotype or the rapid assessment of sex chromosome number that may include probe for SRY and another Y chromosome markers using fluorescence in situ hybridation, named FISH. It's important evaluate the baseline electrolytes and assessment of adrenal and gonadal function, such as testosterone, LH, FSH, and another hormone. And then it's important to do pelvic and abdominal ultrasonographic to individualize the abnormal structure. Then the values of this component, especially the biochemical ones, must be associated with each other. Is very often they do not assume the same value in the patient belonged to the same subcategory of the DSD. In fact, it's a bit of mess. And then the second line testing for specific disorder and associated anomalies is detected by the result of karyotype and another result. We use the genetic testing for specific candidate genes may be promoted by the clinical picture. For example, for the patient with clinical featuring as family history suggesting androgen insensitivity, we test for AR gene which encoded the androgen receptor. Therefore, the genes that I have previously mentioned are evaluated in order to identify the causes, but very often it's not found nothing. It very often is found nothing. Indeed, in these cases, pass to second level method such as chromosomal microarray that detects duplication and deletion that may be too small to be identified on karyotype. And usually we do whole exome and whole genome sequencing. This technique is able to discover that some mutation that don't individuate by the genome panel, and through the whole exome, whole genome sequence of patients and parents, we able to give a more significant value to result. Qua dovevo andare avanti. The management of these infants, which is critical and often controversial in the absence of well-defined outcomes but basic guidelines. It's important requires some multidisciplinary teams, including specialists from pediatric endocrinology, geneticists, and pediatric surgery, urology, as well as psychology, psychiatric, and social worker. This team will be supportive for both patients and whole family, because the birth of an infant with a typical genitalia appearance is often confusing and hailing distress for the family. It's important to refer to a specialized center for children with DSD is strongly encouraged, and the individual with DSD and their families should be offered long-term support to assist in psychosexual and psychosocial adjustment, as well as it's important to have medical support, because it's important to know that the patient with have a Y chromosome and a dysgenic gonad have an increased risk of gonadoblastoma. Thanks to everyone for your attention. I thank the guys from the Journal Club, and above all Matteo, who, despite knowing how much I suck in English, kept me talking about this topic. I hope to have been clear, and above all to induce in you a vision that different from Platonic idea that for each sex there is a single universally correct development pathway and outcome. I hope that everyone regard these individuals as normal superposition of these two curves deriving from the Platonic idea. Thank you.
Thank you very much.
Standing ovation per Annachiara.
Some questions?
Bene. If there are any questions for Annachiara,
Sì, just maybe you were talking about nomenclature before. Is there like a standard nomenclature from the WHO or something that is accepted now? Is it changing? Is there?
Yes, is evolution of the situation, because some classification consider in this group also, for example, Klinefelter syndrome or Turner syndrome, but another study don't consider this form, and now there isn't the right classification.
An actual consensus. There isn't an actual consensus.
Cosa?
Non c'è un
Non c'è-
consensus.
No. Ah, scusa, pensavo che...
Okay, thank you.
You're welcome. Andrea, do you have some question?
Yes, so thank you, Annachiara, for your very interesting presentation. So I wanted to know, so which genetic testing approach are you going to use in your thesis project? So whole genome, whole exome,
I use
panels?
now we use full exome because the time is very short, and
Nice.
And because there aren't money to pay whole genome sequencing.
Okay, and so which class of variants are you going to report? So only pathogenic, likely pathogenic, or so VUS, variants of unknown significance?
Now we don't have the result because we started the whole exome on February, and this I don't know if in July I have the results, but in the genome panel we don't found nothing, and for this we use the genome whole exome sequencing.
Nice, thank you.
I have a question. It's more about curiosity, but I want to ask, like you said that there's a multidisciplinary team that will then like treat the patient. But what's the path, the medical path that a patient like this will undergo to define himself? Like I find it very difficult. Like how does it work?
In San Raffaele, use the approach based to weight the choice of the patient, and because of we have only infant patient, we now don't nothing such surgery, and I don't know why in the future the medical approach is will be.
Ok, thank you.
Quindi
So,
nel
Gaetano.
senso, scusa, faccio una domanda. Scusa, quindi per chiarire questo, cioè quindi diciamo i bambini non fanno visite mediche particolari, è solo magari la famiglia che viene accompagnata un po' con un percorso psicologico.
Sì. Cioè, per il momento i ragazzi del San Raffaele fanno solo appunto l'incontro con lo psicologo, ma non valutano niente.
Okay, so maybe Gaetano can give
loro
us. Oh, maybe Gaetano can give us some surgical insights since he has been.
No, before I ask a question to Annachiara, to be honest, I wanted to know, do you think that at the moment in our hospital, is there like a respectful approach for what concern non-binary patients? Because I heard a lot of stories about like non-binary patients who undergo surgeries where surgeons try to define a gender. So it's like you have to receive a surgery to be part of male gender or female gender. But most of the time, there are people who are just non-binary. And so do you think that at the moment in our hospital, is there a respectful approach for these patients?
I think that because of it's a new condition, because the patient is very small. The same doctor don't able to approach with right approach, and for this wait the time to take a decision. Now nobody do something. Now the doctor diagnoses the causes, and so don't do nothing for management.
Okay.
Yeah, I was thinking maybe, Gaetano, since you have seen this kind of surgery in the adult, I mean, you can give us some insights, some information about, I mean, how is it difficult? Do you think at the moment, like in Raffaele, it would be feasible? Are there centers in Italy that perform this kind of surgery? And is it more difficult, like from male to female?
Pay attention, not spoiler anything about your
so
topic.
are you going to do the...
He's planning to present to...
Okay.
Yeah.
So...
Okay, so I will wait.
If there aren't further question, I think we can end up here for today. Thank you, everybody, and carry on, follow us on Instagram, and see you next week.
Bye.
You all. Bye.
Thank you.
Bye. Thank you.